Hi, welcome to Research Pharmacy 101. I'm a little bit nervous, so just bear with me. I see most of you pretty regularly. If I don't know your name and if I don't know who you are, please come introduce yourself at the end. I think knowing who you are, putting a face with a name often helps how we communicate. Yeah, okay. Oh, I didn't know I should call pharmacy. Yes, if that's where we're starting, it kind of puts me in a little bit of stress because you're probably ready to dispense and I probably don't know what you're doing. And so that's kind of too late. So the purpose of my presentation today is to probably establish when you should call. My first objective today is to establish collaborations and make productive contributions to team-centered interdisciplinary research. I pulled that right off the poster. Basically, that's how can we work together. The next one is to explain what investigational drug services does. We'll define relationships with study team, recognize what we can do together, and then maybe identify other areas that pharmacy can help. Investigational drug services provides pharmacy oversight to all protocols that have IP, investigational product. And moving forward, I will address IP, investigational product as IP. That's what I know it as. We maintain secure storage for investigational product. We maintain the accountability logs for each protocol. We prepare and dispense IP per protocol specifications. I can also help identify dosing and when there should be a dose reduction, or are we at the right targeted dose for each patient population. However, I can help protocol when it comes to dosing, we can. We also maintain temperature logs, and I also create epic orders that is submitted to the build team so that we can have a valid order for each patient that comes through WVU medicine. That's as graphic as I get. So study coordinators, you guys are awesome. You are the backbone to the research. Without you guys, without what you do, this wouldn't happen. You have so much on your plate. High five to you. Yep. So my job is to help make your job easier and better. And so whatever we can do is what we're after. So how many send us a schedule on Thursday by noon of patients that are coming? So part of the communication effort is to that we have established is if we get that schedule by noon on Thursday for the upcoming week, we can plan. And in those, we want patient visits, and we want to know the date and time. We also want to know the protocol. We also want the site evaluation visits or site qualification visits. We also want any monitors. All of this should go on the schedule that you then forward to us. That helps us prepare for the week. That's right. So that helps us prepare for the week. And so with that, patients come first. And so if we have a heavy patient load, Roger and I do all we can to make sure we see all monitors and get to all initiation visits and all monitoring visits and all qualification visits. But we also have to understand that patients come first. And so providing us with those schedules helps us get that done. So some things that we can do together and that we want to be involved on are the qualification visits, also known as site selection visits, budgets, site initiations, site monitoring, audits, team meetings. Invite me to your team meetings. So I try to get to each team meeting at least once a month. That helps me know what's going on in your group. It's easy to get behind. I have probably about 125 protocols doing drug right now. And so in different stages, but all of those are active and all are from different teams. And so keep me in the loop. And then the Epic ordering templates. I need your input as well. So it's important that you bring pharmacy to the site qualification visits. We want to show to the sponsor how great we are. We are great. Our institution is great. And we want them to see all the aspects. We want to hear about the drug that is new to research. We want to hear if there are any unusual storage conditions or any unusual compounding things that we aren't aware of, that we don't have, we can get. We want to know what's the space, you know, how much space is this product gonna require. Space is always an issue. Space is an issue for office space. Space is an issue for storage space. Space is always an issue. One thing that's happening on October 8th, the new Cancer Center pharmacy is opening and we will be ready to go. But what also is in that space is more room storage space and more refrigeration space. I have, as opposed to one 2-door refrigerator, I will now have 2 2-door refrigerators plus a single door refrigerator. As opposed to one room temperature storage closet cabinet, I will now have 2 huge room temperature storage closets. I now will have a dedicated -20 freezer space, which always was an issue. And then we also doubled our -80 freezer space because it seems like as research coming, the -80 is being requested more and more. This is also where we establish what policies we have and what policies they might need. You know, some common policies that they want right up front are our destruction policies. Our temperature excursion policy, and how we maintain and calibrate our refrigerators or our storage space, just storage space in general. So we've been selected, the protocol has gone to IRB, we've negotiated budgets. We're now ready for the site initiation visit. So when you send us the schedule by Thursday at noon, you've also put that we have a site initiation visit. So it's important that I know what protocol it is that we're going to have in the site initiation visit. I want to read that protocol. I want to be fresh and ready. I want to know the specifics of that drug. And so when I come to the table to meet them, I know what they're saying. And I can bring any questions that I have that we don't get or that we're not prepared for. You know, sponsors or monitoring companies, they want to know that you're interested in their protocol and that you can do it tip top. And so that's why I like to know what's coming. It's also the time that is established that if pharmacy has to hold the blind, there are extra steps that we have to take as pharmacy to maintain the blind. We don't want it. We don't want to unblind the PI. We don't want to unblind you if that's how the protocol dictates. We also review how the IP is stored, and we also review, we won't store use hazardous material. It's equally important to keep patients safe, but it's also equally important that I keep our employees safe, and we won't maintain those hazardous drugs that have been used. Per JCO standards, as infection control goes, I also won't take back used patient vials, bags that have gone to the floor, infusion bags that have gone to the floor and been used. Those are JCO infection risk policy or standards that we will not take those back. I also won't take inhalation devices back. Again, infection control. So also what's established at the site initiation visit is, do we have IVRS access? And I hope everyone knows here what IVRS access. IVRS access is a database that does drug assignment or confirmed shipment of receipt. It's important that both Roger and I have that. You know, Roger does a great job receiving all those packages, but if he doesn't have IVRS access, we can't receive those and we can't dispense on those. Also, I am happy to do drug assignment. If a patient comes in and the study coordinator is busy, if I have IVRS access and we've established that I have IVRS access that can do drug assignment, I'm happy to help with that. But we don't want the patient waiting in the chair to say, oh, we don't have anybody that can do IVRS access. Say Sylvia's sick today and nobody checked. So let's make sure that Roger and I both have IVRS access. And then the IP manual. So not every protocol will have an IP manual or a pharmacy manual. And in these are hidden gems like, how long is this drug stable for? Or how long do you infuse it for? Not all protocols give specifications on, you need to mix this in 500 mLs, or you need to give this over an hour plus or minus 5 minutes. If I see a protocol that wants us to infuse over an hour plus or minus 5 minutes, I'm going to immediately say, can we change that to 10? Because I know what happens. That bag has 10% overfill. And if you do the calculation and it's 500 mLs, we won't finish in that plus or minus 5 minutes. I know that just by looking at it. And so it's important that we have this information. And then the last thing on this is the EPIC order. So as an institutional standard, we will, a study coordinator and myself do a double check verification, but we're also sending that to the PI. So they too can take a look at the order and make sure that they are okay with what it says prior to the patient getting this. So now we're ready to, I'm busy. We're all busy. We're all busy. So, show of hands, how many people think I know when a patient arrives? I don't. I have no idea. I know you've given me your schedule, and I know that it's easier to follow on the Beacon side than it is on the clinic side. And we try and we look for those patients. But if I'm not at my desk, I have no idea. And so when you call and say, hey, did you see the order? Nope, I didn't. And so when you call and say, hey, did you see the order I put for John Doe on protocol, blah, blah, blah. He is participant number 123. That's a great call. I am tracking exactly what you say. Again, we have 125 open protocols. I don't know it by the Galactic study. I have no idea what the Galactic study is. I have no idea what the Penelope study is. Those are cute, great names. I have no idea. Please, please, please communicate with protocol number. That's how we file. That's how we track. And so a patient has arrived. You can tell me it's protocol 123, John Doe, participant number 123. And so I can go into Epic and verify that the order is appropriate, and that is what I'm just yes, Sheila. So what we have identified is that Roger and I are both at our computer, and I don't live at a cell phone. A cell phone is a terrible way to communicate with me. It's part of our institution policies that we do not carry our cell phone. And so I'm working out of my email or my alpha pager. And so that really is the best way. Or did I say email? Out of phone call or my alpha pager. And so if you call and I don't answer, I still don't know. I still don't know that that patient's there. And so if you're waiting on me that because you left a message on my phone, I still haven't gotten that message. And that's what we should assume, that I still have not gotten that message. And so that's when you should probably alpha page. And so both Rogers and I's pager numbers are up there. And if I'm not here, my pager has been rolled to Roger's pager, or he's carrying mine. And so we make every effort to make sure both of our pagers are covered. Does that all make sense? Yeah, yeah. It's still, they're both rolled. Mm-hmm. Those are still our numbers. Too fast? Is this okay with everybody? Okay.
Did you say that those are still your numbers?
Yep, they're still our numbers.
Did that change?
So when we moved over to, how many know that we've moved? So you can find us at the first floor of HSC. The location is really from here to that wall to the new oncology pharmacy. And so as proximity goes, because 85 to 90% of our studies are cancer driven, it's really going to be a great location for Roger and I. Come by and visit. When you send us that schedule by Thursday at noon, you could drop it off to us. Thursday at noon schedule. Okay. So patient has arrived. We've received drug. We've dispensed drug. So when that first patient arrives and we've dispensed for the first time, typically a monitor wants to come within that first month. And we're happy, and those monitoring visits go on the schedule. And so we've identified the day that they'll be here. Roger and I won't schedule a time until we look at that day and that morning of. And so often they'll want to schedule with us, but we will not. You schedule them and we'll make every effort to see them. I think in my lifetime here, I probably have not seen, I've been here for over 10 years, I probably have not seen 3 monitors. Now, I also expect them to be here for a full day. If they're here from 11 to 1, I don't know if I can see them. But if you tell me they're here at 9 o'clock and they're here at 1:30 because they have a flight out at Pitt of 4, we will make every effort to meet them. That's going to be a communication thing as well. Roger does a great job. I'll take this time. Roger does a great job. Roger takes care of all the monitor visits, and he's really great at it. He's always prepared and has everything printed or copied for them before they even sit down. He has already done drug returns. He really does that effort, and I'm really lucky to have him. Audits. Okay, so they're necessary. We must be involved. So if there is a protocol that has IP, pharmacy is going to be involved in the audit. We want to know as soon as you know. Just like you go through your folders, we need to go through ours. Our goal is to always be audit ready, but it's also necessary for us to go back through and identify anything that could have gone right or wrong, and what exactly happened, and do we have that documented. If you need copies for that audit, let us know. We will, we'll do everything we can to make our site the best that it is. Policies. So these are like the 4 that we kind of live on. If you need additional policies, so often we are asked, is there a transport policy? We don't. So we fall under one medical center drive. The cancer center falls under one medical center drive. All our clinics fall under one medical center drive, unless it's out at UTC and they have specific storage space. So I'm going to segue. Anybody do offsite trials? Hi. So, so if you do offsite trials, we're
Actually, I'm not doing any drug studies yet.
perfect. Shush. So if you do offsite, pharmacy has oversight on all spaces throughout the institution that has drug storage. And so before you are able to store drug, I have to come make sure that it's a secure location, double lock. Is there temperature monitoring? Who has access? And then I have to do quarterly inspections. And that is not my rule. That is governed by my department. And that is governed by pharmacy law. And so pharmacy has to have oversight. So if you are planning that, get me involved now, because I'm probably going to say, oh, you need this. And so let's do it before the drug gets here, because you're not going to be able to store it. As opposed to, let's do it before as opposed to after. All right, we've done a great job. We've worked hard. We've enrolled 82 patients. Everybody got the right dose. Everybody got it at the right time. High fives, everyone. So now it's time for a closeout visit. For pharmacy, closeout visits take a little bit longer than just a regular site monitoring visit. This is where they go through and they either destroy all IP that we have on site, or we ship back. And so when you fill out those schedules for the week and send them in on Thursday at noon, put out that there's a closeout visit. And so then we'll follow up with that monitor to say, oh, are we sending drug back? Oh, are we going to destroy it on site? If we're sending it back, they need shipping containers. We need to make sure that we have packaging, a filler. We need to make sure we have a big enough container. And then we also need to be able to get it to the doc. And so those are all helpful if we know it beforehand. So what also happens at the closeout visit is we'll make sure that all accountability logs, all drug that is either come in or dispensed in this protocol has been accounted for. We close out all accountability logs. I sign them as a pharmacy designee, or sometimes the PI is required to sign per the sponsor, and then date them. Then we'll make photocopies for that monitor to take with them. And then they'll also take copies of temperature logs from the lifetime of the IP at our institution. They'll also often want copies of all shipping confirmations, shipping receipts, confirmations. And then any note to files, deviations, we'll all put that in the closeout visit papers. Once that's all been done, we will close our binder and send it to the regulatory group that is housing this protocol, and they will marry it and close it up and store it for the longevity of the sponsor's requirements all together in one. Pharmacy will not hold any more protocols that we've closed. Does that make sense to everyone? So there's a few that we have to hold on to. And those are the protocols that are blinded. So I have a couple protocols that I still have to house because the PI is still blinded. And there's always like a couple, oh, there's an outlier. So that's the nature of what we do. You can't be surprised by an outlier in what we do. There's always seems to be one or two comes up.
Lisa,
Yeah, I'm sorry,
do
Sheila.
you want to close out for investigator-initiated trial?
You know that yes, we should, because it's a great way for us to say, you know, we've done all these. These are any of the outstanding issues that we may have had, and then we close it. We make sure the PI knows it's closed, and then we can back to you for the housing of that. And then, you know, it's also a great way to final up any budget issues that are still out, you know. So I also do billing. And so I do all patient billing that pharmacy is involved in. And so if you haven't gotten a bill from me, let me know. Encore. How many people know Encore? We love Encore. And so I'm not requiring everybody to use Encore. I'm telling you why we love Encore. Encore is the house, the electronic house that houses the most current approved, IRB approved protocol and IB. And it is the easiest way for me to find what protocol or amendment are we dispensing out of? Are we treating the patient out of? It also houses patient information. It gives us participant ID information. It tells us if they're still on or off treatment. It lets us know how many people are still on treatment. It's really user friendly, and it's a great way for us to identify protocols. The reports that I can also run in Epic to see what we're doing. It's really user friendly, but more importantly, why it's user friendly is because we're getting Vestigo. So what Vestigo is it is an electronic database that helps us with accountability logs. And so pharmacy, we've signed the contract. We have not set a date where they're going to come and install it, but it interfaces with Encore, and it also interfaces with Epic. And so it increases and safety of patients, increases the accuracy of dosing and the safety of patients. I think safety of patients is absolutely like top of our priority. It also helps us make sure that we'll have drug for when the patient comes in. And it also will help us with billing. And so I know that that's an extra, but that is part of my job. And so it will release some of the burden. And I think that's a great thing for me. So in summary, I've talked about interdisciplinary efforts are key to success, teamwork. We discussed what and how we manage a protocol. We've identified some areas where we can work together. And then if anybody has any suggestions that you need from us that you're not getting, please let us know. I know that there's room for growth, and I know that we can make it better, but sometimes my box is just this big. Anybody have any questions?
Sorry, just this one, because we have another presenter right now. Maybe we can do a question period at the complete end, or you can talk to Lisa at any time. Sorry about that, but we want to make sure that Traci has time for her presentation. Thank you, Lisa.
Can you guys hear me okay? I don't know if this is on, is it? Okay, I'm just going to try to stay within the confines of my cord.
So the reason I am talking to you today is very much like Lisa's presentation, is to talk to you about if your study needs lab testing or pathology materials, what do we need from for the laboratory to be able to support that need? And just like Lisa, if you're ready to start tomorrow and you need labs and you're just calling us, we got an emergency as well. So first I wanted to just mention, when we say labs, what does that mean? So this is a list, and I won't read it all to you, but these are the areas that our laboratories encompass, from the blood bank to our anatomic pathology sections, microbiology, molecular. We have a phlebotomy team that draws inpatients. We also have phlebotomists in the POC that draw outpatients. So all this is under the umbrella of the laboratories, including pathology, which sometimes, you know, people don't recognize that that's also part of our areas. And we also have an outreach area, university medical labs. They go out and bring specimens from other hospitals, other clinics, doctors' offices, and that kind of work back to us as well. And even some studies, we have actually used outreach, our outreach arm, if, like, let's say you need phlebotomy collections, because they do have some phlebotomists that can come to sites, and as well as just maybe a need, an off-site need that you need collections or pickup or something. Sometimes we can have our outreach help with that. But by and large, it's what goes on here within the campus. So a little bit about the laboratories. We are CLIA and CAP accredited. CLIA is a CMS obligation that all laboratories that perform testing have to have what's called a CLIA certificate. We currently have 2 now, because if you have a different physical address, you have to have a separate CLIA certificate. So when we moved our molecular lab off to what's the old PREEP building, the Operations Support Center, whatever it's called today, we had to get a separate CLIA certificate for that particular operation. So that's why you'll see that we have 2 CLIA certificates. Last year we billed about 3.3 million tests. That equates to roughly 1 million samples a year come into the labs. That's about 4,000 a day. So that's part of the reason why I'm speaking to you, is we try to incorporate the study work into the workflow of the clinical labs, but the study samples that we might get from 1 or 2 patients a day also has to work into that 4,000 samples that are flowing through the lab at any given time. And part of the bane of our existence is standardizing our processes and our workflow so that specimens move through the lab in a timely manner. But these are different. So every study is a one-off from that practice. So that's where we have to really coordinate to be sure that we know what's needed of the study, so that we can meet your all's needs as well as meet the 4,000 patients that are going to need testing from us today. Our primary reference lab is the Mayo Clinic, Mayo Medical Laboratories. So that's where that's our first choice of where we send labs, but we also can send to other clinical labs if Mayo Clinic doesn't provide it, and sometimes that's the case. If you ever have a question about a test, we have an electronic test menu, test catalog. You can look up any tests we perform in our laboratory, as well as it's a joint electronic catalog with Mayo. So if it's a test we send to Mayo, it's integrated into that manual as well. And some of the tests that we send to other labs that we've chosen besides Mayo, we can also put in that manual. So it's like, it used to be a thick notebook that we try to distribute on paper, but the electronic one has made life smoother. And if you get the presentation by email, it's linked there, but you go to Connect, Lab Services, and then you can link to our lab manual. So what kind of support do we provide to clinical trials? Well, we can do lab tests in our lab. So if you need a CBC or some chemistries, things like that, we can do that testing in our lab. We can send to a reference lab, like if you have a test that we don't perform, but we can send it to Mayo, we can send it to ARUP labs, those kind of mainstream labs, LabCorp, Quest, those kind of labs. These are approved tests, so they're not research tests. So keep that in mind. We cannot perform research tests in our clinical lab or in our pathology labs. We can also provide process specimens. So sometimes you just need us to process the sample, be it centrifugation, aliquoting, freezing it, storing it, et cetera, we can do that and then ship the samples out either as they come or at your request if you want a storage and a ship once a month, that kind of thing. And then tissue and slides, which has become more and more prevalent as we are doing more cancer studies, that we're doing a lot more tissue support and slides out of our pathology lab than we ever have before. I wrote myself some notes, some little notes, so let me remember here what. Okay. So I want to introduce Mary Ann DeVallo. She came with me. She's our point of contact in the clinical labs. So she's who takes care of the paperwork and setting the account up, getting requisitions made and those kind of things. I did it for a long time for those of you guys that have been here a while. And Mary Ann is now taking care of that. And then I'm still there and I help support her and review a lot of them too. So we work together, but she is probably more available than I am on any given day. So this is the information that we absolutely have to have in order for us to set up your study within the lab. We have to have a copy of your protocol. We need, which I didn't include that, did I? We need a copy of the protocol. We need to know what the title is and the nickname, because we do like to give them catchy names, much like we do everything around here, it seems. Who's the PI? Who's the coordinator responsible? What your IRB number is, because IT requires that IRB number. They use that as the identifier within Epic. So we have to have that number. The address of where invoicing should go to, because our bills are going to generate from patient financial services, just like a patient bill does, and you'll get a monthly invoice. We need to know who that invoice needs to go to. And we need to know, and I'll get to a little more explanation, if it's an anonymous study or if it's not anonymous. And we also need to know where results are going to need to go to. If the results are just tests we perform in Epic and you can look at the results in Epic, that's fine. But if it's anonymous, or for some reason you want a paper copy of your results, we need to know where that can be, where you want that routed to. Because we can have the system auto fax it. We can have the system print to a networked IP printer usually within the hospital or the health science center. So let's answer the question. So this is one of the things that Mary Ann will ask you as soon as you send a study to the lab is this an anonymous study or a non-anonymous study? IT needs to know that for the way that they build the study, because it's important on whether or not we're going to allow results to flow to the patient's med record, or if we're not going to let it flow to the medical record. So the definition is, if it's anonymous, it means we're not going to use the patient's name or their MRN, and no results are going to go to Epic. So if you need, we're going to always use some kind of code or something like that, and it's not relevant or necessary for that information to go into the patient's med record, that's going to be an anonymous study. A non-anonymous study would be, it's perfectly fine. If you order labs on me, it's going to go to my med record. It's going to be viewable to my physician. It's going to be just like any other test. The reality is, just behind the scenes, it's going to bill to your study account. Okay, so those are the differences. We absolutely have to have this, because the way Epic works is you can create an account within just the lab system, and we can do things, and it doesn't cross over to that bigger picture of Epic. So we always have to have an answer to this question. So for example, so let's go through the several different scenarios that we might have. So you need clinical lab testing. It's not going to be anonymous, so we're going to use the patient's name. And the tests that you need are orderable in Epic. So it's the run-of-the-mill stuff, CBCs, maybe a lipid panel, some cultures, electrolytes, that kind of thing. So how are you going to go about setting up that study? There's an email in Outlook, there's a distribution group called Research Billing, and that goes to a multitude of folks. And the most importantly of that group is it goes to the IT folks that need to know this information so that they can build you an order set in Epic. So if you're doing, like I said, run-of-the-mill type test, you're going to get an order set behind the scenes. It's going to be tied to your study. You can order it on your patient. We'll run the labs, because we're not going to, let's say you need a creatinine. We're not going to do anything different with a creatinine because this patient's on a study. It's the same lab test. The important thing is that we're routing the billing correctly. So they're going to build you an order set. You're going to use that order set. If you don't use that order set, you're going to bill your patient. And then it will specifically bill to the study, and that will be taken care of all within Epic. So in reality, if you have no need for anything outside of that, you just email that research billing group. we don't really need to do anything from our standpoint. So next, so what if you need clinical lab testing, anonymous and non-anonymous, either one would, it really isn't, it's not relevant per se, but they're going to ask the question, so we have to answer it one way or another. But you just need us to process samples and ship them out. So the only thing that's going to get generated from us is a bill, because we do charge by the specimen for processing those samples. And we charge a fee for packaging up and shipping. So if you need us to process the sample, it's going to be really important that we get a copy of the lab manual. So with your protocol, there should be a lab manual. Covance is an example, Quintiles, those type of labs where you send samples to that we process. So to Mary Ann, you need to send a protocol, your IRB approval letter, we've developed a research request form, which I'm going to set up here if anybody would like to take, because it kind of goes along with these slides, and it gives us the information that we need in one place, pathology and clin labs included. So if you'll take that copy, we'll be glad to email it out, but this would be helpful to get this completed when you send us a study, so we have that information. So send that to Mary Ann, including the lab manual, because the lab manual is going to be the key that tells us how we're going to process those samples. Used to years ago, they seem simpler. Now they're even more complicated than they've ever been. It seems like you have to, spin this tube and do this with this tube and all these types of things. And like going back to what I said before, if we're getting 4,000 samples a day, and this is the one thing that's handled different than everything else we've received today, we really need to give our staff the guidance to be able to do that. We don't have people dedicated specifically to this because we need it to be able to go into our workflow 24/7. So we need it to be able to be handled by any of the staff that potentially could process a sample. So this is what you need to do, and this is just a little snippet of what the top of what we call the blue sheets, because we always use blue paper. It helps our staff. It's kind of that visual that they know it's a study because it's on blue paper for that requisition that we're going to give you. So what if you need in-house testing and you need us to process some samples? So in a non-anonymous situation, you're going to do the same thing that you did for the ones that you need to be orderable in Epic. You're going to send the email to the research billing group, because that's going to be the people to make you an order set. And then you're also, though, going to need to send to Mary Ann the things that you would have sent because you need us to process samples. We need the protocol, we need the IRB, we need the request form, and we need the lab manual that explains what you need us to process. And sometimes it's not very clear. I mean, the protocol talks about all these labs, and then, you look at it and you think, okay, we're going to perform it. And then somewhere in like one little sentence, it mentions they're going to go to a central lab. Well, then we need a central lab manual to support what that processing looks like. We'd like, so an order set will be created for those tests that we perform in-house. You'll take care of ordering those that way. And then a blue sheet will be created for how we're going to process those samples that are just going to come to us for processing and send out. A good example is the regular labs are going to be done for us, but the patient has PK samples. So those PK samples, those may be what's going to come to the lab for processing. We're going to store them and ship them once a month, but you're going to do CBCs and electrolytes and things like that through your order set. Okay, does that make sense? Are we good so far? So next, let's say you have in-house testing and central lab. So this is going to be a little bit different in the fact that we talked about if we do the test in-house, you're always going to have that order set. Well, if your patient's going to be anonymous, we can't order that through Epic, because we're not going to put patients that have a name like Mickey Mouse. We're not going to put non-patients into Epic. So if you need tests to be performed in-house and to be processed and it's anonymous, we're going to have to make you a blue sheet. So because we're going to need to bring it to the lab, and we're going to need to order it in such a way that the results don't cross over to Epic. We're going to use whatever code, whatever number you want us to use in identifying that patient, and we're going to send you those results on paper. Nothing's going to go over to Epic in that situation. Okay, but the needs are the same as to what needs to go to Mary Ann. Protocol, form, IRB, lab manual. Okay. So next, let's talk about pathology. So, but let me pause. Does anyone have any questions about the clinical lab stuff and how one of the things I did mention that we do charge a fee for the specimen processing. It's by tube. So you need to build that in your budgets because we do, that's a lot of manual work that we need to account for within the department. And if you've already, back on the ones that are going to need both a blue sheet and may have an Epic order, if you've already submitted for the Epic order, let Mary Ann know that, because the account that exists in Epic is still usable for our purposes. They're not two different accounts. It's just something else is going to be needed to be done in Beaker, which is the lab system. So let Mary Ann know that. I've already sent the email to Research Billing, an order set's in process, because then she can tap in to the work that IT is already doing to build the account, and then we can take it one step further and get the lab part built. Same is true as we talk about, and I have some helpful hints at the end, so I'm giving those away early, it appears. If it has clin lab work and pathology needs, let her know that too, because the account's still going to be the same in Epic. It's just we have to build it in Beaker, which is for the clin lab side, and CoPath for the pathology side. Okay, so let's say you need tissue or slides from our pathology lab. So you're going to do the same thing you did with the clin lab studies. You're going to email Mary Ann. She needs the protocol. She needs the IRB. She needs the request form that gives us a lot of good information, as well as the lab manual. So the lab manual sometimes goes into more extensive detail on what they need specifically for the tissue. She'll create a blue sheet with what the tissue needs are. Sometimes it's slides, sometimes it's other things. The study account will be billed just like for the clinical labs. It'll be a monthly invoice from Patient Financial Services. And when you need to pick those things up, you'll pick those up from the histology lab. Does everybody know where that is? Second floor, Health Science Center. So that's where our histology lab is, and that's where you would pick up any tissues or slides that you need. So it's not our policy and our routine practice to release blocks or the tissue itself. Some studies offer an alternative, but if it offers an alternative of slides with the tissue, we're always going to choose the slides, because we need to keep the tissue and the block here on site if at all possible, because especially today, because there's so many molecular tests, there's a lot of need to go back and test folks on archived tissue for their standard of care as well. So we don't want there to be no tissue available in case there's other things that need to be tested for. And there's also legal ramifications. If we had a tissue and there's some question legally on a diagnosis, we try to keep the tissue on hand. So if slides are offered as a choice, we're gonna go with the slide choice. If they absolutely insist that this study only will allow for the tissue blocks in order to participate, we will, with prior approval by our medical director, we have to have the anatomic pathology medical director review that protocol for us and make sure that he's on board in allowing that to be the case. Or more and more frequently, we've been seeing that the study requires the patient to have a tissue biopsy completed just for the study. And if it's just for study purposes, we like to ensure we're going to have you mark on the blue sheet, and that our expectation is the patient has been consented and agreed to that biopsy for study only purposes, because we can't diagnose or do anything with that if we hand it off to a sponsor and it's gone. If they need both, then we'll do both, but we're going to hold that tissue until we've done our part. Okay. So here's a few just helpful hints, like I mentioned. If it has both clinical lab and pathology work, request it together. If we need a point of contact, so when you say someone's the coordinator, if you know that coordinator is only here one day a week, give us a couple of options, because that blue sheet is like a requisition that comes to the lab. So if that sample comes to the lab and we find out that it's not testable, it gets spilled, there's an issue of some sort, we have a question about whether we're shipping that day or not, we need somebody that we can contact when those samples are dropped, because stability could be an issue and we need a point of contact that we can reach. Okay. If there's more than one coordinator working on the particular study, let Mary Ann know that so that she can put both folks on the blue sheet as a point of contact. If the coordinator changes, which sometimes happens, please let Mary Ann know that too, because we don't want to keep putting requisitions into the lab and there be a question and, you know, find out, well, that person hasn't been here for 2 years or a year or whatever. We want to be able to contact the relevant person at the time. And if you haven't gotten it to Mary Ann yet, and today you need to send a sample to the lab, just mark through the blue sheet and put the right name. That's fine. She looks at those every day. She could catch it that way and fix it, but it'd be nice if you notified her ahead of time. And if we have incomplete information, so if we just get an email that says, hey, here's a study, and we get a copy of a protocol or a snippet and it says we're starting tomorrow, we can't turn that around like that. Mary Ann works, she also has a lot of other duties besides studies. She does a lot of the billing for our lab, and also IT. It's a process. There's no way to move like the wheels of justice. The wheels of IT move at a certain speed. So nothing bad about IT. It's just the reality. Everything has an IT component, and we can't. We want to try to prevent calling them with emergencies that we could have had some preventable way to have done this ahead of time. Okay. So there's Mary Ann's email and phone number so that she can be reached. There's also mine. So if you ever have any questions or anything, if you have folks outside that aren't here, please, we're going to put the form and we're going to put this presentation on our webpage, because there's lots of new folks out there that seem to don't have a lot of guidance on what they're supposed to do. And I think Mary Ann is hoping that this, and if we can get the information out, it's going to help us with that. All right, I think the walls are coming down, so I think that's probably a sign.
Right, thank you very much.